Good afternoon, everyone. We are going to study today about cardiomyopathy. We'll study first the different types of cardiomyopathy, then we'll go into its pathophysiology and the cause of each type. Then we'll look into the clinical features and examination findings. And at the end, we'll go for studying the management part where we'll study the prevalent investigations and treatment. So, starting first with the hypertrophic cardiomyopathy. It's the most common form of cardiomyopathy. Coming to pathophysiology, there is asymmetrical septal hypertrophy. The left ventricle free wall thickness is increased. As a result, the volume of left ventricle is reduced. It is also known as their banana shaped ventricle. And volume is reduced, so diastolic dysfunction starts occurring. And there will be also, in later stage, subvalvular aortic stenosis and systolic anterior displacement of the mitral valve, causing left ventricular outflow obstruction. So, as a result of diastolic dysfunction, there is syncope during any strenuous activity, and due to left ventricular dysfunction, there will be pooling of blood into lungs, causing pulmonary edema. There will be chest pain on exertion, effort intolerance, and even sudden cardiac death can also occur in some cases. Now, coming to examination findings, they are really simple. Like there will be double apical impulse as the atrial is also contracting against the against the hypertrophied left ventricle. There will be pulses, bisvariance is seen, jerky pulse is there, narrow split S2 sound is here, ejection systolic murmur is also heard due to aortic stenosis. Pulses bisvariance, the reason behind is that there is a sudden rise and fall due to left ventricular outflow obstruction. In investigation, we go for transthoracic echocardiography. We will see the left ventricle free wall thickness to be increased. There will be LVH seen in ECG, and in the treatment, we give beta blockers. And if they are contradicted, like in asthma patients, we go for central calcium channel blockers like verapamil. Now coming to the second, which is our there are some intervention treatments like implantable cardio defibrillators can also be used. Septal ablations can be also done if the left ventricle wall thickness is greater than 30 mm. Now coming to restrictive cardiomyopathy, it's a rarest form. Here the size of the ventricle is normal, but the atria is dilated due to the stiff ventricles, and we see here pink hyaline deposits, and the cause of it is amyloidosis, glycogen storage disorder, radiation, sarcoidosis, hemochromatosis, scleroderma can be the causes. Clinical features are like the compliance is reduced of the both right and left ventricles, so there will be changes of left heart failure and right heart failure. In the left heart failure, you will see pulmonary edema, PND, orthopnea, dyspnea on exertion, whereas from the right side you will see beta edema, ascites, the small signs, and hepatomegaly. And in the treatment here, in the management in ECG, chest X-ray is done, and left ventricle end diastolic pressure is here increased. Treatment is ICD. Warfarin is given to reduce the risk of thrombosis. Diuretics can also be given. Last is the dilated cardiomyopathy seen in alcoholics, post-viral myocarditis, toxins, muscular dystrophy. There is thin down ventricles, all chambers are dilated, multinucleated myocytes are seen here. Dichrotic pulse will be seen, S3 sound can be heard. There will be soft S1 sound, pansystolic murmur can be seen, the apex beat is shifted laterally. The treatment is ICD. And you can also give diuretics and ACE inhibitors here. And here the ejection fraction will be reduced, whereas in hypertrophic, the ejection fraction was normal.